Good afternoon to everybody. I'd like to take this opportunity to welcome all my faculty colleagues and the physicians and clinicians from the Center of Excellence of the states, the office bearers and members of IMA, and officials from the Ministry of Health and Family Welfare. This is the ongoing Center of Excellence program being conducted by the Ministry of Health and Family Welfare and the All India Institute of Medical Sciences, New Delhi. And today, I think we are discussing another very important topic, and that is managing children with COVID-19. It's important for us to understand that children are not little adults, and we cannot translate what we are doing in adults to children. They need to be treated separately, and that is why this webinar that we're having today is very, very important. There's also been a lot of concern about the severity of illness in children in this current wave, with some reports from hospitals in the US saying that they are seeing an increased number of children being admitted. So I think it's important to clarify how is the current Omicron wave behaving as far as children are concerned. The concern has always been that the younger children are not vaccinated, and are they really getting more severe disease? So I think that is also something important that will be discussed in the webinar of today. Also, the issue of post-COVID sequelae with Omicron. Are we going to see more of multi-system inflammatory syndrome of children, or are we going to see something else? These are other issues which will also come up. But I think the important issue is, what is the management for children who are having COVID-19? What can we give? What should we not give? What should we really treat? And how should we treat these children depending on their age group and their presentation? So we have a whole panel of experts led by Professor Deorari, the head of Department of Pediatrics. We have Dr. Rakesh Lodha, Professor of Pediatrics, Dr. Kabra, Dr. Anant, Mohan, Dr. Manish Soneja, and of course, the colleagues from the State Center of Excellence. And I would really encourage all of you to either raise your hands if you have any comments to give, or put your questions on the chat box. I'll now pass it over to Professor A. K. Deorari to conduct the subsequent proceedings, and he can then also coordinate as far as the questions are concerned regarding the pediatric age group. Over to you, Professor Deorari.
Thank you, Professor Guleria. And I'm so happy on behalf of Department of Pediatrics, All India Institute of Medical Sciences, along with Ministry of Health and Family Welfare, we are conducting this very important webinar on management of COVID in children. I welcome all the faculty members and participants from Institute of Excellence who have joined. And I'm very sure, as Mr. Love Agarwal said, whatever you are going to learn during this webinar, you would take it forward by passing it to more medical officers and frontline workers. Management of COVID in children is much different as compared to management in adult. And as we know, Omicron does affect the children, but it is a mild disease. So we also need to keep in mind that the fear and the panic which is getting created among the families, we must be able to curtail it. And this webinar is going to re-emphasize all those points. So with me are my faculty colleagues who are going to make presentation. First, it will be by Professor Rakesh Lodha on epidemiology and testing for COVID. And then it will be followed by management of COVID in children and small amount on MISC in children by Dr. Nitin. And with me are the panelists, Professor S K Kabra and Dr. Anant Mohan, who have joined. We will take all your questions, which will be written in the chat box or on the YouTube, and then they will be answered by all the panelists. So with these words, I would request Dr. Rakesh Lodha to start his presentation. Over to Rakesh Lodha.
Okay, so I will just have a brief update on the management of pediatric COVID. And over next 40 minutes or so, we are going to cover a little bit about epidemiology of COVID-19 in children, update on the mode of transmission and diagnosis, followed by clinical features, assessment of severity, clinical features with Omicron, with whatever we know from published literature, update on therapeutics, and treatment as per severity, and an update on Misc as well. So I think we all are conversant with this, the current status globally, more than 317 million cases, more than 5.5 million deaths. In India, again, we have started seeing a spike over last couple of weeks, and this spike is much sharper than what we had previously. Thankfully, it has been mild so far, and in last 1 week, more than 1 million cases have been reported, and about 2,000 deaths have been reported in the country. Now, in children, this just shows data till some time back, which essentially showed that the individuals less than 20 years were less than 12% of all positive cases. And this is our population pyramid, and we would have about 35% or so people in this age group. So we could see that children and young adults seem to be less frequently affected. We are still awaiting the data from in the current wave, and hopefully we would have soon. But from what we hear from colleagues and what our experiences, that the pattern is likely to be similar. In absence of the country-specific data, we'll look at some other data from rest of the world, and this is some data on age-specific incidence from the United States, which is currently undergoing, they're seeing a lot of Omicron cases. So if you can see the overall incidence per 100,000 population, in various age groups, that's less than 5, 5 to 11, 12 to 15, and then 16 to 17, is kind of similar or lower than what we see in adults, except the elderly, where for some reason it seems to be low. Now, here the difference is that individuals beyond 12 years of age have been vaccinated, or at least a fair proportion have been vaccinated. Interesting to look at is that what is the contribution of children to the weekly cases, and this is again data from some of the regions of the United States, where in different age groups, less than 5, 5 to 11, and 12 to 17, we can see that over a period of time, there has been an increasing contribution from, of pediatric cases. So the proportion has steadily been increasing, and that could mainly be attributed to the vaccination of the adult population and a relatively greater contribution of children to the overall case positivity. However, if we look at the weekly deaths data, so here what we see is that overall, what we are seeing, the predominant mortality or high risk of mortality is in the elderly. And if you look at children and adolescents, there's hardly any mortality, even though the hospitalizations may have been there for last few weeks. Now, for us, the vaccination has been started in the country for adolescents 15 to 18 years old, and at this time point, Covaxin is what has been offered, and lakhs of children have been vaccinated in a short period of time. Other vaccines which are in pipeline are the DNA vaccine and the Covax, the subunit vaccine, which we are likely to see more coverage over a period of time. Now, the likely reasons for the surge, I think we all are aware about this, that it's predominantly the Omicron variant of concern which has been there, which is different from the earlier variants. In a background of maybe, the COVID appropriate behavior not being optimal, there would be a lack of adherence to distancing, proper mask uses is not very commonly seen. And in addition, mass gatherings and all have been there. So in that background, it's predominantly the introduction of this highly contagious variant which has led to the surge. And that's what is happening, this kind of just from the global tracking of the genomics of the COVID or the SARS-CoV-2 virus, we can see that gradually over last couple of months, it's been replaced predominantly by the Omicron strain, and even our data is likely to be the same. Now, this is from the data from the InstaCog, which is kind of tracking the genomes of the SARS-CoV-2 virus in the country. And this is data collated till end of last month, where predominantly it still was Delta. There was a fair bit of others. But from what we hear is that now, from late December and early January, the dominant strain, at least in metros, has been the Omicron. And that could explain the rapid surge that we are seeing in the number of cases. And the same thing is applicable for children as well. Now, what we need to see is that are children more frequently affected? I think we need some data, and I think that data is likely to be available soon. But apparently, there doesn't seem to be any dramatic increase in the proportion. The absolute numbers are likely to go up as the cumulative or the total number of cases increase in the country. Now, why are children less frequently or less severely affected? And I think more importantly, it is like children are less severely affected. A lot of children get infected, as has been shown by the sequential sero surveys in different parts of the country. So there are issues around the target receptors, that is the ACE2 receptor, as well as the other protein, cell surface protein TMP RSS2. And there are age-related changes which may be kind of influencing to what extent the infectivity of the cells is there. Then there are issues around the disease being more severe in elderly, mainly because of the expression of the differences in expression of the lung ACE2 receptor. What is also important is the concept of trained immunity. And it's believed that due to the various live vaccines and frequent viral infections in children, there's a strong innate immune response, and therefore there is an early control of infection at the site of entry. Specifically in response to SARS-CoV-2 infection, the innate immune response seems to be better, and various markers like interferon alpha-2, interferon gamma, IP10, IL-8 and IL-1 beta, these protein levels have been shown to be higher in nasal fluid of children as compared to adults, which means that they respond to the virus in a better way. In addition, if the lung gets involved, then the excellent regeneration capacity of pediatric alveolar epithelium would help with more rapid and a more complete recovery. And the absence of risk factors of like various comorbidities that we see in adults and elderly, like smoking, diabetes, they obviously are less frequently seen in children. So all of these contribute to less severe disease in children. Now, again, in terms of the modes of transmission, I think we know about the predominant modes: the contact transmission, the droplet transmission, and the airborne transmission. And the control measures would slightly be different. So in the initial part of the pandemic, there was a lot of emphasis placed on contact transmission in addition to what was thought to be predominantly droplets. So a lot of surface disinfection and all was in practice in various areas, both healthcare facilities as well as outside those. Now we clearly understand that the major mode is likely to be airborne, and therefore the precautions have to be of a different level. The Omicron is clearly more contagious, and again, the values of R0, which kind of gives an idea about how contagious it is, how easily it can spread. Various groups have estimated it to be much higher than what was there for Delta and for the original virus. It's believed to be more than 7. Some groups have estimated even to be close to 10 or more than 10. And in that scenario, it comes close to measles, which is a highly contagious disease that we see in children. Now, in terms of the diagnostics, I think the diagnostics remain the same. With Omicron, there hasn't been any change in what we are going to use for diagnosis. So they could be either RT-PCR or CB0 on respiratory specimen, and these specimens have to be collected properly. There's some reports now coming up that saliva may be a better, biological fluid to test, but I think some of these need validation on larger studies. The point of care tests have their utility in a setting of high background positivity, high pretest probability of the COVID being there. However, what we need to understand is that a negative test doesn't rule out the infection. And in this scenario, we would have to rely on the PCR-based tests, and there are various platforms that are available. The current tests show positivity with Omicron. So, the concern that the current tests are going to miss Omicron, it's not there. For identification of the variant, one would have to do sequencing, but from what we understand, predominantly it does not have any role, at least as of now, in absence of any specific monoclonals that may be available for at-risk groups, which is not the case with children. We really don't need to worry about what particular variant it is at this time point, and therefore sequencing is not required routinely for patient management, and one need not wait for these reports to decide what the management would be. Now, the COVID-19 in children would have both direct and indirect effects. So acute respiratory infections, lower respiratory tract infections, Of late, there would be children who have GI symptoms or other systemic features. Then the illness of multisystem inflammatory syndrome in children and adolescents that was temporarily related to COVID-19, this has been seen. And I think we'll just have to wait and watch whether this particular surge is also followed by increase in cases of MISC. And then there would be atypical presentations, various neurological involvement, and all which have been reported. The indirect effects, again, have been there previously with lockdowns and the healthcare services being affected, which led to downscaling or closure of regular child and maternal health preventive services. These, to a great extent, there has been an attempt to catch up. Closure of schools has been a big issue in terms of learning, excess screen time, access to education for a group of children, various mental health issues, and also about nutrition because of maybe some impact related to the school nutrition programs not being available during this period when the schools were working on an online mode. So with this, I'll hand over to my colleague, Dr. Nitin, to talk about the clinical features of COVID-19, discuss about the severity and protocol-based management of the acute COVID as well as multisystem inflammatory syndrome. Dr. Nitin.
Thank you, sir. So if we see the incubation period for the previous variants or previous waves, so the median incubation period that was described was 5 days and which could extend up to 14 days. But with the Omicron, the initial data suggests that the incubation period may be lower and it could range from 2 to 5 days with a median of 3 days. Clinical phenotype, the typical clinical phenotype with COVID-19 that can be defined as pre-symptomatic, that is the period between exposure and onset of symptoms. So it is important because in the late pre-symptomatic period, the child may be infectious to spread the infection. Also, some of the children or a large number of children can have asymptomatic infection. So the tests are positive for respiratory specimen for COVID, but there are no clinical signs and symptoms of COVID. Classical manifestations, they are indistinguishable from any other acute respiratory tract infection, so which includes fever, cold, cough, sore throat, and shortness of breath in some small number of patients. And some of the children may have atypical manifestations or extrapulmonary manifestations. So these include gastrointestinal symptoms, which can be seen in up to 5 to 10% of children. And these may occur without respiratory symptoms in children. And diarrhea, vomiting, and abdominal pain are the common symptoms. So some of the children may develop some cutaneous manifestations, which include maculopapular, urticarial, and vesicular eruptions, and transient livedo reticularis. COVID tos was also described with the previous waves, and which shows that there are some reddish purple nodules over the distal digits, and it is seen predominantly in children and young adults. One of the important post-infectious or inflammatory syndrome, which is multisystem inflammatory syndrome, is seen in children, and this will be discussed in later part of the presentation. So with the current surge due to Omicron, what we have seen is that there is greater proportion of upper respiratory tract infection, and some of the initial lab data suggests that the Omicron's growing potential in the lung cells is less compared to the previous variants. There is limited data in children as of now, and what has been seen from the initial series from the South Africa, that there is lower risk of hospitalization even with increasing number of the COVID cases. And this is one of the figures which suggests that even though this is the data from the Delta variant or wave 3, and this is the from wave 4 or Omicron variant. So even though the cases are increasing rapidly, but at the same time when there were similar number of cases due to Delta, the mortality was significantly lower with Omicron compared to the Delta variant. So the initial data suggests towards a milder illness due to Omicron. So this is from a preprint which has included 139 children admitted to public sector hospitals. So what they found was that 55% of the children had some or the other comorbidity. And COVID-19 was the primary clinical diagnosis in 43%, as a contributory diagnosis in 18%, and it was incidentally diagnosed for children who were admitted for some other reason in close to 37%. The predominant symptoms were fever and cough in around 40 to 45%. Small proportion also had vomiting, shortness of breath, diarrhea or convulsion in around 20% of children. And minority of them may have headache, skin rash or other symptoms like body aches or painful joints, etc. And what has been seen is that the cases due to Omicron, when they were matched with the Delta variant, the previous surges, it has been seen that even in the pediatric age group, the number of emergency department visits have been significantly lower in the Omicron surge compared to the previous surges. And also the hospitalization have been lower in 0 to 4 year age group, and they tend to be lower in older children also. When they compared the proportion of children of the all cases between Omicron and Delta, that doesn't seem to be very much, and between the two waves. Now coming to the mortality due to COVID-19 in children. So this is data from previous surges up to February 2021 from 7 countries. And what has been seen here is that the deaths in pediatric age group due to COVID, the proportion of deaths to the all-cause deaths has been very low, which is less than 1 to 2% in pediatric age group, whereas the same proportion in adults has been 3 to 40% of all-cause deaths in the adult age group. Now, which children are at risk of severe disease? So again, there is limited data, but the studies from India suggest that around 40 to 60% of hospitalized children with COVID had some comorbidity. And majority of those children who died due to COVID-19 had a comorbidity. And this is the global data. The risk factors for hospitalization include presence of type 1 diabetes, obesity, congenital heart disease, epilepsy or convulsions, neurodevelopment disorders, chronic respiratory disorders, and immunocompromised patients. Now coming to the therapeutics. So there had been multiple trials for drugs in adults, but the clinical trial data is limited in children. So in the latest living guideline by the WHO, there have been recommendations for pediatric age group also, but most of these are derived from the adult evidence. But due to similarities in the pathogenesis, so it's likely that the impact of interventions would be similar in children also. Initially, once the child is diagnosed with COVID-19, we have to stratify the severity of the illness. So it is classified into mild illness, moderate illness, and severe illness. So mild illness typically presents with the upper respiratory tract infection with fever, sore throat, rhinorrhea, and cough, and there is no fast breathing. The moderate illness corresponds to the WHO definition of pneumonia, which includes fast breathing. That is for children less than 2 months, respiratory rate of more than equal to 60. For 2 to 12 months, respiratory rate of more than equal to 50. For 1 to 5 years, respiratory rate of more than equal to 40 per minute. And for more than 5 years, respiratory rate of more than equal to 30 per minute. Also, the saturation should be, for moderate illness, should be more than equal to 90%. And these are the children which will be classified as moderate illness. In severe illness, if there are any features of severe pneumonia, so that include any child presenting with pneumonia, but also having low saturations less than 90%, having clinical cyanosis, or there is severely increased retractions, or there is increased respiratory efforts, which includes in grunting, or there are other features of severe disease like seizures, altered sensorium, etc. Also, any critical illness like ARDS, sepsis, septic shock, multi-organ dysfunction will be included in the severe illness. So one has to follow the local guideline for management of COVID-19. So this was the last published guideline by ministry was in June 2021, and hopefully a new guideline will come up shortly. The treatment we will discuss in further slides. So once the child is diagnosed with COVID-19, so if the disease comes under mild disease, then there is no additional blood test or chest imaging is needed in these children. If it is a moderate disease, then initial complete blood count, including ESR and blood glucose, and a baseline chest X-ray needs to be done. In severe disease, apart from these tests, we also have to do tests to see for inflammation like CRP, ferritin, D-dimer, and organ dysfunction with LFT and KFT, and chest imaging should be done in these children also. If there is mild illness, children can be managed by home isolation unless there are some specific reasons which will be discussed further. There should be symptomatic treatment in form that for fever, paracetamol 10 to 15 mg per kg per dose, 4 to 6 hourly. For throat soothing, in older children, they can do warm saline gargles, or honey can be used in children more than 1 year of age. And we have to maintain adequate nutrition and hydration. What is not indicated in mild illness are cough suppressants, antibiotics, steroids, antiviral drugs are molnupiravir, fluvoxamine, or any specific monoclonal antibodies. In some conditions, the home isolation may not be feasible, like if there is small house, overcrowding at home, or there are high-risk patients staying at home and inadequate facility to isolate the patient, or there is regular monitoring is not possible due to any reasons. So in such children, these patients can be admitted to some COVID care centers and monitoring can be done there. Also, if there is some comorbidity or high-risk factors like immunocompromised children, children with underlying chronic disease, so these children may also be admitted in the hospital for monitoring, especially if the monitoring is not possible at home and facilities for urgent transfer are not available nearby. Danger signs that should be monitored by the parents at home are the difficulty in breathing, fast or shallow breathing, or if there is any noisy breathing like grunting in infants or inability to breastfeed, any blue lips or face, chest pain or pressure that is felt, any new onset confusion or inability to awaken or not interacting when awake, or inability to drink or keep down any fluids. Home isolation, the latest guidelines suggest that at least 7 days should have passed from the onset of symptoms or date of sampling for asymptomatic or pre-symptomatic cases, and the patient should be afebrile for at least 3 days. There is no need to repeat the test after the home isolation period is over, and asymptomatic contacts need not undergo testing, and they are to follow the COVID appropriate behavior. For moderate disease, that is children with pneumonia, they should be admitted to dedicated COVID facilities. Oxygen supplementation should be given to children. We have saturation between 90 to 93% to maintain a target saturation of more than equal to 94%. Supportive care should be continued, including antipyretics, nutrition, hydration, rest, and close monitoring. Empirical antibiotics or antivirals are not indicated, though the latest WHO guidelines suggest antibiotic may be considered in children less than 5 years. Systemic steroids are not routinely administered in moderate disease, but if there is very rapid deterioration in hypoxemia, that is within 6 to 12 hours, the child is admitted without hypoxia but start developing saturation up to 90 to 93%, or children who were admitted with hypoxia but without any features of severe disease, but they are rapidly progressing to severe disease. In children with severe disease, such children should be admitted to a COVID-19 HDU or ICU. Supportive care, including oxygen support, should be given appropriately. In older patients, awake-prone positioning can be considered, and empirical antibiotics should be given in this group. Corticosteroid is the drug of choice, and the dose being 0.15 mg per kg per dose for dexamethasone once daily, or 0.75 to 1 mg per kg per day for methylprednisolone. Very important that we monitor the blood sugar values for children who are on corticosteroids. Tocilizumab, there is no trial data in children, but the latest WHO guidelines, they recommend that they may be used in severe hypoxemic COVID-19 pneumonia patients in children also. For ARDS, the management is similar to the standard ARDS guidelines. So for mild ARDS, there can be given a trial of HFNC or NIV can be given, and awake prone position may be considered in older children if it is cooperative. But we should be monitoring the respiratory status very closely, and if the respiratory distress doesn't improve with these measures, they should be quickly switched over to invasive ventilation. In severe ARDS, mechanical ventilation is recommended with the low tidal volume of 4 to 6 ml per kg with high PEEP. Cuffed endotracheal tube should be used to deliver high pressures as well as to prevent cross infection. A restrictive fluid approach should be given, and if there is poor response, prone positioning should also be tried. In patients presenting with shock, the cause could be a septic shock, or there could be viral myocardial dysfunction due to viral infection. So the initial management include giving bolus with crystalloid solutions from 10 to 20 ml per kg, but they should be given slowly over 30 to 60 minutes if not hypotensive. But if hypotensive, these boluses can be given more rapidly. But it is very important that the fluid administration should be given cautiously, because there is high chance that there could be myocardial dysfunction in these patients. So early inotrope support should be given, and we should monitor closely for fluid overload, and deresuscitation measures should be instituted if needed. The following drugs do not have any role in management of COVID-19 in children, which include hydroxychloroquine, ivermectin, antiviral agents, and immunomodulator drugs like interferon beta-1A or convalescent plasma infusion. Now a little bit about the MISC. So the first reports were from Europe in April 2020, and the surge is typically followed by a gap of around 1 month from the surge in the COVID-19 cases. Overall, it is uncommon, and less than 1% of all COVID-19 in children and adolescents. And among the children who are hospitalized with COVID-19 or related complications, it forms less than 10% of such patients. The definitions are the same. The WHO criteria should be used for diagnosis of MISC. So any children and adolescents between age 0 to 19 years with fever more than equal to 3 days can have any two of these symptoms, which includes rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation of oral cavity, hands or feet, and presence of hypotension or shock, presence of cardiac involvement in form of myocardial dysfunction, pericarditis, valvulitis or coronary abnormalities, evidence of coagulopathy or acute gastrointestinal symptoms. Along with that, there should be elevated markers of inflammation such as ESR, CRP or procalcitonin, and no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcus or streptococcal shock syndrome should be there. And there should be evidence of COVID-19 by either a PCR positivity or serology positivity or likely contact with patient with COVID-19. Common mimics for MISC, because it's a multi-system involvement with multi-organ dysfunction. So things like bacterial sepsis, dengue shock syndrome, rickettsial infection, chikungunya fever, fever with acute abdomen, Kawasaki disease, toxic shock syndrome, severe COVID, other viral, severe acute viral infections, myocarditis and macrophage activation syndrome. So these are some of the differential diagnoses, and they should be considered, especially in tropical areas. The tropical infection should be considered as a common differential diagnosis. So there should be a stepwise evaluation for MISC. So if there is a child with unremitting fever with epidemiological link to COVID-19 and clinical features suggestive of MISC, then it should be evaluated for MISC. If these are not present, then the child should be evaluated for alternate diagnosis and should be monitored so that if there are new features coming up and he fulfills the definition of MISC, then should go for evaluation protocol for MISC. We should see that some shock or life-threatening manifestations, if they are not present, then we can have a tiered approach. So we can have some initial evaluation, which is screening evaluation. If the screen is positive, then we can go for tier 2 evaluation, and also there should be workup of other tropical infection. But if life-threatening conditions are present, then we have to act quickly and we have to evaluate for tier 1 and tier 2 test as well as tropical infections at the same time, at the time of admission itself. If the criteria for MISC is fulfilled, then we should see if any of these are present, including cardiac dysfunction, coronary involvement, multi-organ dysfunction, or life-threatening conditions. If these are present, then we may start treatment while completing the other evaluation. If life-threatening conditions are not present, we should rule out the tropical infection. And if the criteria for MISC are not fulfilled, then we should consider alternate diagnosis and also monitor for features of MISC in later on. So what are the tier 1 tests? So tier 1 tests are complete blood count, complete metabolic profile, LFT, KFT, and blood gas and blood glucose, CRP and or ESR, and SARS coronavirus 2 serology and or RT-PCR and blood culture. Positive tier 1 screen, the both should be there. So either CRP should be elevated more than 50 milligram per liter or ESR more than 40 millimeter per hour. And at least one of these should be there. The absolute lymphocyte count of less than 1000, platelet count less than 1.5 lakh, hyponatremia, neutrophilia, or hypoalbuminemia. If tier 1 screen is positive, then tier 2 test should be done to in detail evaluation for organ dysfunction, which includes cardiac evaluation, panel of inflammatory markers to follow up with the therapy, blood smear, and SARS coronavirus 2 serology if not already done. And it is very important to rule out the common tropical infections like malaria, dengue, enteric fever, and rickettsial illnesses like scrub typhus as appropriate. Management of MISC, the latest WHO living guideline includes recommendations for MISC also, and the recommendation suggests that for children with fulfilling the criteria for MISC, the first line treatment is corticosteroids. And if there are features of Kawasaki disease, then corticosteroids should be added to the standard care of Kawasaki disease. So we have this stepwise treatment for MISC, so that if there is MISC with shock or multi-organ dysfunction, we have to give a combination of methylprednisolone 2 mg per kg per day and IVIG 2 gram per kg over 12 to 16 hours, and empirical antibiotic should be started as per hospital antibiogram. If the symptoms persist for 48 to 72 hours, or if there is early worsening, high dose methylprednisolone can be tried in such patients, and experts should be consulted for role of biologicals. If there is features of MISC but not shock or MODS, but there is also fulfilling criteria for Kawasaki disease, methylprednisolone 1 to 2 mg per kg per day and IVIG combination should be given. If symptoms are persisting after 48 to 72 hours of treatment, then consult to specialists for biologicals. If features of MISC are there, but there is no shock or life-threatening condition, first investigate for tropical infection. If negative, IV methylprednisolone 1 to 2 mg per kg per day should be used. If the symptoms are persisting beyond 48 to 72 hours, there should be role for high-dose steroids, IVIG, or biologicals. So to summarize, with the surge, more children are being affected. However, the profile of illness doesn't seem to be changed. The confirmatory tests are RT-PCR, CPNET, or rapid antigen test on the respiratory tract specimen. Classification of disease severity is based on the clinical status, and no investigation is required for classification of severity. Children can be managed at home if they are asymptomatic or only mildly symptomatic. If moderate and severe illness, they should be managed in inpatient facilities. Management is predominantly supportive with monitoring and steroids in the severe group. No new drugs for use in children are recommended, and rational use of medication is required. MIS is conditions related to COVID-19 in children, but it is uncommon. But it is very important that we diagnose it early and rule out common differentials also. Immunomodulation with steroids is the key in the management. And vaccination in children has been started, and it should be initiated in a phased manner. Thank you.
Thank you, Rakesh and Nitin, for making an excellent presentation. Can you stop sharing your slide? Okay, wonderful. So it looks like, listening to both of you, the current surge which is happening at this point of time is due to Omicron. And the best part is children are majority of the time asymptomatic or only mild symptoms in children. And as Rakesh said, it is an aerosol mode which is responsible for spread of infection, and the RO value is more than 7, so it's highly contagious. Home isolation is a key, and for that, Government of India has given a guideline which are released on 5th of January. It is there on Ministry of Health and Family Welfare guidelines. And as rightly pointed out by Nitin, the management of Omicron is more or less the same how we were managing Delta COVID in the previous wave 2. Not much change in the management. We need to keep a watch on follow-up, whether following Omicron we have increased rates of MIS-C in children. So data collation, follow-up of children, and then sharing with each other is going to be the key if we have to win this battle against Omicron in children. So Sushil Kabra, there are few questions for you. I am addressing them to you. So there is a question by Dr. Tripti, is why mortality in children is less, as Rakesh showed. So that is one question. And the second question is, what is the pathogenesis that Omicron infection is more contagious? Sushil Kabra. Kindly unmute yourself. Yeah.
We are learning about the how the virus is behaving and why it is affecting less to children, and why there is a low mortality. That is not yet very clear. And as Dr. Rakesh has presented, that it may be related to ACE2 receptors, trained immunity, or absence of serious illnesses like diabetes, hypertension, and other things in children. That's why it is less commonly affected, less severe, and low mortality in children. Still, we need to learn more about it. That may help us in prevention of the same mortality severity in adults also, once we understand the immunology.
So thank you, Sushil, re-emphasizing the fact that if your child is healthy, chances are most of the time the child will be asymptomatic or only mild infection. It is only children with comorbidity who land up in problem. So we have to take care of children with comorbidity so that exposure to them can be curtailed. Sushil, there is one question commonly asked is, and I would like to hear from you on this because you guide World Health Organization also on this. What is the role of antiviral and monoclonal antibodies for treatment of COVID infection in children? Sushil.
Yes, sir. As it was pointed out by Dr. Nitin, that even the WHO living guideline, they have taken certain action regarding the recommendation of various antivirals and monoclonals and other interventions. And majority of these recommendations are based on randomized control trial carried out in people who are more than 16 to 18 years of age. So first and foremost is that there are no published evidence of efficacy of any of these drugs or safety of these drugs below 18 years of age. But WHO feels that if the biology is not very different, then possibly we can extrapolate in certain circumstances the same medication in children also. So as of now, without any ambiguity is use of steroids in severe disease. That is also to a restricted 0.15 milligram of dexamethasone per kilo. Otherwise, the newer antivirals, including remdesivir, fluoxamine, molnupiravir, sotrovimab, they have not been cleared for use below 18 years of age. So they do not have any role in pediatric patients or pediatric practice.
Thank you, Sushil, for bringing this to the notice of everyone. It is very important that in children, the role of antivirals, which are new antivirals and monoclonal antibodies, is not there. And I'm also happy to share with all the centers of excellence and all the members of Indian Medical Association that Government of India is going to come out with revised guidelines for children, in which again this is re-emphasized, which is developed by 25 experts all around the country. So thank you, Sushil, for bringing this to our notice. My next question goes to Rakesh Lodha. Rakesh, question for you is, I can also answer that if there is an infection with Omicron, after how many days the vaccination should be taken? I think Government of India guidelines says wait for 3 months.
So I think we are just, what was the guideline previously? I think the same thing is likely to be applicable from the guideline perspective. So I think we'll follow the same one.
So Rakesh, another question for you is, for severe COVID infection, do we have to give antibiotics always?
So I think the guidelines have addressed this issue, and what they clearly say is that you would give empiric antibiotics only if there's a strong suspicion. So one is there is a scenario where there is a definite infection, bacterial infection, which needs to be treated. And the second would be if there's a strong suspicion that one feels. So in that scenario, one would use an antibiotic, send appropriate cultures and all, and take a call whether to continue or de-escalate based on those reports and response in the child. The WHO kind of, even for moderate and severe disease, is more inclined, the guidelines are more inclined to use antibiotics in children less than 5 years of age. I think that's because the overlap and concern whether this is actually COVID pneumonia vis-a-vis just let's say incidental finding. And in that scenario where we are using antibiotics for pneumonia based on clinical diagnosis, I think the same thing is applicable, and that's been extrapolated to these conditions as well.
Sushil, there is a question for you which you always love to answer. What is the indication for taking a child from home to a DCHC, which is a COVID health center? That means, what are the red flag signs in children?
So as it was clarified by Dr. Nitin's presentation, that first thing is we train parents to monitor children at home who are having a mild disease. And they should always see respiratory rate, chest indrawing, feeding difficulty, or child is lethargic. If any of these things are there, the parent should immediately contact the doctor who is supervising the child. If it is not possible, then take the child to nearest hospital immediately. Other thing is that if possible, we can do oxygen monitoring, which may not be feasible or possible at many times, specifically in children, to monitor home oxygen by pulse oximeter. But if that is less than 94%, then the child should be taken to immediately to the COVID care hospital.
Thank you, Sushil. So I think, Sushil, there are a lot of requests in the chat box that people want all the PowerPoint slides. I am very sure Rakesh and Nitin have no objection in sharing those with all the participants.
Yes, sir. We will be more than happy to share it, and we will give it to them.
Wonderful. And I would also request all the participants to kindly log on to iGot Diksha platform, in which COVID care in children and newborn, wonderful lessons are there, for which you have to take MCQs and you can generate your certificate. Use them for teaching learning, self, and for teaching learning of your medical officers and even the nurses. So the modules are for nurses also there. So Rakesh, there is we already covered this. So again, there is another question by Inamdar is, what is the recommendation for booster dose in patients who have suffered Omicron infection? I think we already covered that. And so there is one more question which relates to maybe Rakesh for you. There is a child who is rat antigen positive. He had fever and he threw a convulsion. Should we do a lumbar puncture on that child?
I think, I guess you need to know the age of the child. So if you presume it's, I think the concern may be about febrile seizures and possible concern about CNS infections. So I think if one is looking at a febrile seizure and it's a typical febrile seizure, one wouldn't really go ahead and do a lumbar puncture in that setting. On the other hand, if the child is presenting with a febrile illness, has seizure, the seizure is prolonged or is atypical, or the sensorium is not doesn't become normal after 15 minutes or so. In that setting, considering a CNS involvement, now whether it's related to COVID or not, that's very difficult to say. In that setting, the management protocol would remain the same. I don't think we're going to do anything separately for a child who is rat test positive.
So I think this is where your clinical judgment is going to you have to take a decision. Majority of the febrile seizure between the ages of 6 months to 2 years, majority of the time it is simple febrile seizure. You don't have to do any lumbar puncture. So look at your patient, individualize it. If you suspect something which is going to be very, very serious like meningitis, you have no choice. Otherwise, it may not be needed if it is febrile seizure, as Rakesh Lodha said. So, Rakesh, there is a question for you. For how many days, if RT-PCR is positive, the patient is going to be asymptomatic or symptomatic, is going to be spreading that, is going to be infective to others?
So again, I think the period is likely to be variable, but I think what we know is that that particular individual needs to be in home isolation for a period of about a week. There would be a subset of individuals who may still have the viable virus in the respiratory tract beyond 7 to 10 days, and but we need actual, the viability studies to prove that. So we can safely presume after 7 days or so, the probability of spreading infection would be minimal. Such an individual, again, means this is more for older children and adults, that they should be using a mask. Younger children, that's not possible, but their caregivers should use the appropriate mask and the other COVID appropriate behavior to reduce the risk of infection. The exact period of infectivity would be variable. As he said that, mostly it would be by 7 to 10 days, most of them would be thought to be non-infectious.
Sushil, there is I think this is answered in the presentation. Will MISC follow after the Omicron surge has passed off? This is a question asked by two persons.
Yes, sir. It is difficult to say whether Omicron will behave differently as compared to the Delta, but we do not have any reason to say that it will not follow this MISC. So we should be looking for some surge in cases of MISC after 2 to 4, 6 weeks. So therefore, we should be having a high index of suspicion for children presenting with MISC after say 2 to 4 weeks of this surge.
Okay, so I think there is another one question which relates to evidence and data, which is getting collected at this point of time in the entire country about what is happening to children with Omicron while they are getting admitted, whether they have comorbidity or not. So I think that data is getting collected. The same is we have to wait and watch, as Sushil is saying, whether MISC is going to follow with Omicron infection. So I think it is our responsibility, each pediatrician's responsibility, and each Institute of Excellence responsibility to collate and help the government of India to collate that information and evidence, so that we are wiser while we manage and go along the surge and while the surge is coming down. So Rakesh, Lodha, there is a question in reference to pulse oximeter which is getting used for home isolation, that the pulse oximeters are not reliable. So can you just guide people, if we have to believe a reading of pulse oximeter, how it has to be taken properly, and when should we say that is the correct reading of pulse oximeter? Rakesh?
Yeah, sir, I think that's an important point. So most of these devices that are available over the counter are the finger probe devices, which are typically good for an adult, for that finger could be put in. For a younger child, particularly an infant, it may be a challenge to put it in an appropriate size. So mostly, in very young children, one may either put it over the palm or on the foot, and in older children, it could be put on the finger. And it has to be attached properly. And thereafter, I think it's good to look at a pulse oximeter or procure one which shows us the waveform or the pleth along with the readings of the heart rate, the pulse rate, as well as the saturation. Once the probe is put, the child shouldn't really be moving that limb. So it's a child who's very restless and is throwing around, in that setting, it would be difficult to get an accurate reading. We should look at a regular waveform on the plethysmograph to believe that that particular reading is likely to be appropriate. One would also look at the heart rate or the pulse rate values that are going to come in with that. If they are excess, means this needs actually confirmation, and that could happen by a trained healthcare worker predominantly. So once the waveform is stable, the readings are stable, and this typically may take 30 to
Rakesh, we can't hear you. Can't hear you.
So the mic is on. Am I audible now?
Now audible, yes.
Correct. So I think the pulse oximeter has to be corrected properly. In infants and young children, it may be difficult to put it on a finger. And in that setting, it may be put on the palm or the, the toe area is what one would put it on. The plethysmograph, that is the waveform, should be visible on the screen of this pulse oximeter. And one should see a regular waveform on this, and correspondingly the readings of the pulse rate as well as the saturation should be stable for a few seconds. And this typically may take 30 to 60 seconds in various devices. And only after that, that reading should be noted. If the peripheries are cold, we are unlikely to get a reliable reading, and one therefore has to be cautious. One shouldn't take the reading which we get immediately after putting on the pulse oximeter. Very often it's a low value which may be there, and the parents are likely to, for obvious reasons, likely to panic. And therefore, if we are giving pulse oximeter or telling people to use pulse oximeter, we also need to tell them to use it properly and note down the readings only when the readings have been stable for at least a few seconds.
Thank you, Rakesh, for clarifying the use of pulse oximeter. And I think it has to be used properly, and you have to make sure the child is not moving the place where the pulse oximeter is put. And it should not be only one reading. It has to be multiple readings before you say it is below 94% saturation. Thank you, Rakesh. And I don't see more questions, neither, unless Rakesh, you have on YouTube. I have taken all the questions which were there in the panelist chat box and on attendees question answer platform.
So I think, so there's one question about special precautions for treating a child with COVID with comorbidities like thalassemia, sickle cell anemia, and diabetics. So do you want to respond to that? So management in children who are detected to have COVID infection and have underlying disease like thalassemia, sickle cell, or let's say diabetes.
So these children may be at risk of severe disease. So the management will depend upon the severity classification like any other COVID-19 infection. So the thing is that for patients with comorbidities, even if they have mild illness, so the parent should be guided like how to monitor the child at home. And if the monitoring is not possible, then such children may be admitted even if they have mild illness. And otherwise, the protocols for management remain same irrespective of presence or absence of comorbidity.
It is very important to understand that many a time the children with comorbidity, say some chronic disease, leukemia, thalassemia, or having a nephrotic syndrome who are on a long-term steroids, they have a more morbidity otherwise. So if a child was brought to an emergency for the deterioration of the primary condition, and incidentally you find that it is a COVID infection is positive, so we should be very careful in providing the full supportive care for their primary underlying disease. Otherwise, what happens is that once it is a COVID, the child is getting transferred to the COVID care hospital, and then the primary disease treatment is slightly neglected. So that is very important. If there is definitely a COVID-related pneumonia, then we can follow the algorithm which already we have discussed. But the primary care of underlying disease for which the patient has visited emergency should not be neglected. That should be provided full care.
So I think this is very, very important. While we are caring for patients with COVID, we should not forget management of non-COVID illness, which may be underlying comorbidity. Children will become more sicker due to comorbidity rather than COVID infection which has occurred. So management of underlying disease is much more important in addition to whenever you are doing management of COVID. Sushil, there is one question which is by Dr. Sheetal Parekh. She is asking that in her clinic, she is saying with cold weather which is around, lot of kids with upper respiratory tract infection with 1-2 spikes of fever and suspected COVID. What should be done? Do we do rat test on them or send them for testing or just leave it? Sushil.
As of now, as per the guideline, we are supposed to investigate or test all those who are presenting with acute respiratory problem or influenza-like illness. And therefore, it is advisable that we do a test. Though the question comes that what we are going to do, we are managing them at home. But at least we can take a precautionary measure to prevent infection in the other high-risk people who may be elderly grandparents or someone who is at high risk of having a diabetes and other thing in the family. So once we diagnose that this child is suffering from COVID or Omicron, then appropriate action can be taken to prevent infection in others. So as of now, till we have some major change in the guideline for testing, we should continue to test. As far as which test to be done, one is that if the pre-test probability child is symptomatic, as of now, you can go for a RAT test, rapid antigen detection test. If that is negative and still child is symptomatic, then you can go for a RT-PCR.
So Sushil is correct. See, while we have to keep in mind a child can be a super spreader also. If the child has infection, he is going to go home. He may infect the grandparents and the other members of the family. So kindly make sure that you do the test. It may be a RAT antigen test which can be done, and make sure it is not a Omicron infection. Okay, so I see one more question, Rakesh, is on co-infection with Omicron. Any data, any information on this?
Sir, I think what probably it means is that there is some other infection and like we also detect
typhoid, malaria, dengue.
I think these have been reported. I don't think we have appropriate numbers. Again, the data that came in from South Africa, about 40% of the children had other reasons, or let's say only 40% of the children, the admission could be attributed to COVID alone. In the remaining, it was along with some comorbidity, which was the dominant reason for admission. And about close to 15-20%, it would be where COVID is also playing a role, but the underlying illness is also there. But I think that's an interesting question, but we need published data on this. It's not uncommon to see. So the important part is that one would look at the clinical picture. And in that setting, one would decide. So a present child who has prolonged fever, week, 10 days or so, and if you are suspecting enteric fever, an incident and the COVID test is also positive, then one would it's likely that there is a background illness, and on top of which there is also the COVID test is positive. Whether that's causing disease or a pneumonia and all would need a clinical evaluation.
Thank you, Rakesh. So at the end, let me ask each three of the panelists who are sitting on the dais, starting from Sushil, kindly give 2 carry-home messages, key messages, and kindly don't repeat the same. Sushil.
Yes, sir. As of now, this is a cause of concern that Omicron has a very high infectivity rate. But at the same time, we should not panic. It is less severe, and children with comorbidity should be evaluated and monitored very carefully if they develop a disease.
Thank you, Sushil. Let me ask Nitin. Nitin, you want to add 2 key carry-home messages?
Yes, sir. And also for the treating physician. So it's very important that the management is to be done as per the guidelines, and medications like steroid, they should be used in select patients with severe disease only. And the dosage should be also be used appropriately. And one should avoid using very high doses like pulse methylprednisolone upfront for MISC or severe COVID in these children, because that is going to cause hospital-acquired infections and fungal infections. So we should be very careful to go stepwise with our approach for both severe COVID and MISC.
Thank you, Nitin. But as we learned from both the presentation, it looks like the disease is only mild. It is not moderate to severe. And we are also not sure at this point of time whether it will lead to more MISC in children. We have to wait and watch and see over the next 4-6 weeks how the things unfold. Rakesh, Lodha.
So I think what we need to keep in mind is that while we think about COVID and febrile children, I think we should continue to consider the possibilities of various other causes that we're going to see in children of a particular age group at various time points. We shouldn't be missing the other diagnosis just because a COVID test is positive. And therefore, a good clinical approach is what is important. And adhering to the guidelines, which is essentially, if you look at it, is essentially supportive. The pediatric guidelines are not really mentioning any specific drugs, and it's good supportive care with which most children are going to do well. The other children, again, the treatment supportive care would be guided by additional conditions that they have. So I think it's more like a rational approach that we have to take to make sure that we don't do any harm.
Thank you. So at this point of time, let me put on behalf of Department of Pediatrics, my sincere thanks to our beloved director, Professor Randeep Guleria, for giving us the opportunity of sharing our learnings on COVID with all of you who joined for this webinar. And I am also thankful to Ministry of Health and Family Welfare, especially Lava Agarwal, who included the topic of management of COVID in children in the series of webinars which are being done for all members of Indian Medical Association, professional organization, and all the institutes of excellence who have joined in this series of webinars. So once again, I would wind up by saying that Omicron, though contagious, majority will be asymptomatic, few will be mildly symptomatic. Home isolation is going to be the key, and we must test and isolate patients who are positive, and also keep on looking at Ministry of Health and Family Welfare guidelines, which are on the website for home isolation. And we expect even the revised guidelines are going to be out for children. So kindly look at that. And I would request Sushil, Nitin, and Rakesh to share all the PowerPoint slides which they presented today with all the participants, all the centers, so that they can take it forward for educating more healthcare professionals for COVID management. And I also request everyone to go to iGot Diksha platform to look at the lessons which are created for management of COVID in children, newborn, for the doctors, for the nurses, and they will be very useful for managing COVID in children. Thank you. Thank you, Sushil.
Right. Thank you.
Rakesh, Nitin, and Director Sir, and Lava Agarwal, and all those who joined in this webinar. Thank you so much. All the best.